Well, hello everyone, and welcome to the Quizzify Valid Vendor Series webinar. And our topic today will be the first ever TPA whose performance is guaranteed by Quizzify. And my name is Mark Delicave, and I'm going to take a moment here to introduce our panelists. Al Lewis is the person on the left there. He's our CEO and Quizmeister-in-Chief of Quizzify. Quizzify teaches employees health literacy using a quiz format designed in collaboration with doctors at Harvard Medical School. Al also literally wrote books measuring wellness outcomes, which became the basis for the Validation Institute. He's been called the wellness industry's troublemaker in chief, and that's by his supporters. What his detractors say can't be repeated in a family forum such as this one. Now, Al will be leading the discussion today with a high-quality TPA benefits administrator. And the person in the middle of the screen you see there is Diane Deinhardt, and she's Vice President of Client Services at Nova Healthcare Administrators. And Diane has been leveraging her expertise in self-funded solutions, and with that, she empowers clients to choose the most relevant benefits for their members. And Diane brings more than 20 years of experience in benefits administration, and she's been serving Nova's clients for more than 10 years. Now, also joining us today is Jennifer Peteresi, who is currently the Director of Risk Management and Insurance Services for the County of Niagara. Jennifer is responsible for the administration of the county's self-funded and excess insurance plans. Jennifer has been working in various capacities with the County of Niagara for the past 16 years. Now, Jennifer happens to be a client of Nova Healthcare Administrators, and she has joined us to give a firsthand account of the work Niagara County and Nova have been doing together. And now I'm going to turn the talking stick back to Al to lead from here.
Thank you very much, Mark, and thank you for everybody for joining us, especially my co-presenters. Oh, here we go. So the big news is that we have selected Nova as Valid Vendor of the Month, and I know a number of you have been on our other Valid Vendor of the Month webinars, so you know that this isn't just one of these awards that people give out in order to get attention to themselves. We actually put our own money. We put a third of our fees, Quizzify's fees, at risk for any joint account that we have, not for our own performance, which we go 100% at risk for, but for the performance of the actual Valid Vendor of the Month itself, in this case, Nova. Now, why would we do something like this? Because we essentially lose money on an account. I don't mean lose profit, I mean actually lose revenue. Well, we only do it in a few cases. You have to meet certain specs. One, you have to be validated by the Validation Institute. Two, our standard is actually higher because remember, this is our money at risk. So that's a threshold, being validated by the Validation Institute. We have to think you're even one of the best of the validated vendors. Now for member-facing entities, meaning carriers, TPAs, large employers, our standard is that they must significantly outperform industry averages in avoiding wellness-sensitive medical events, the 5 that you're most familiar with. Let's see how Nova is faring when measured on these events by the Validation Institute. Okay, so the first thing that you do as a validator is you say to Nova and all the other organizations getting validated, give us your total number of ER and inpatient primary admissions for all the ICD-10 codes that collectively represent these 5 chronic conditions. Remember, we're just looking for the people who fell through the cracks, because theoretically, in the under 65 population, in theory, if you manage these diseases tightly, very few people should end up in the ER or the hospital. So you're looking to keep those numbers down as low as possible. So then, the organizations being validated collect these things, they put it in a little grid that we give them, and then we, Validation Institute, this is we Quizzify, but I'm also we Validation Institute, which I founded way back when, compare or in this case, Nova's results to the other results. And drum roll, let's see how they did in per thousand. Okay, we're going to show you a couple of examples. This one is CAD, which is heart attacks, angina, and other ischemic events. Per 1,000, the national average is about 2.5 events per thousand, and Nova comes in under 2. So that is a significant difference between those two lines. And then, if we go to diabetes, the difference is even greater, with the national averages being at 2.5 ER visits and admissions per thousand, whereas Nova is more like 1.5, which is one of the best in the database. Now, I am going to turn the talking stick over to Diane, who will give you some color on how Nova keeps these rates down, not just for asthma and diabetes, but also other chronic, other diseases, other conditions, other reasons to go to the hospital. And then we're going to circle back and show you how much they've improved since we've known each other. So Diane, to you.
Thank you, Al. So I'm going to give you a couple examples of where we take a strategy or look at a particular issue such as ER visits and have two different strategies based on client. So in the first situation, we reviewed a client's data and we discovered that members were not taking their maintenance asthma medications or they were not picking up their diabetic supplies. So through some outreach programs, we discovered that the copays for that particular group were high on that on both the asthma medications and the diabetic supplies. So we recommended to the group that they remove those copays altogether. And we knew that it would spike their plan pay just a little bit in the short term, but over the long term, it decreased their ER and inpatient admissions significantly. So they more than recuperated the cost that they spent on the patient's copays. And again, it's a win-win for both the member. They have better access to care, they're maintaining their health, and it's a win for the plan because they are seeing a decrease in the dollars that they're spending on their health care. And the next slide, same situation, we have high ER utilization, and we dug into this client's data and we realized that they had a high number of pregnancies. And those pregnancies, a lot of them were new mothers. So what we did was we created an outreach program in which the nurses would outreach in the third trimester, and they would help those mothers set up a pediatrician, get in contact with a pediatrician, locate urgent care centers near them, and remind them that they have access to the 24-hour nurse line. So put that in your phone, have it readily available, and that did significantly reduce the number of times that they were in the ER. And it really was just, a nervous mom that didn't know what was going on with their children, and nobody wants to be in that situation. So by giving them the appropriate care available to them, again, the plan reduced their spend, and the members won in the long run as well. The third one really is, again, an example on a Niagara County member. So Jennifer here, who's with me, we approved an outcome for a Niagara County patient. We used a strategy for inpatient stays that included active discharge planning and post-admission outreach by a registered nurse. The strategy begins immediately when we receive that request in for authorization, our utilization management processes, and it continues through their inpatient stay and concurrent review. The clinical team worked with the facility, the attending providers, and the primary care providers to manage the transition of this member's care from an inpatient setting back to their home. And it really ensured that they had a safe and appropriate discharge to their home. The clinical team coordinated with the treating facility to make sure that the member had access to resources that let them continue their rehabilitation and the maintenance of their health post-discharge. The programs that we have include initial outreach to the plan participant within 72 hours of the discharge. And it reviews their instructions for their medication adherence, as well as allows that member to question the nurses on anything that they didn't understand. When you come home from a hospital, you're not always the most coherent. So a couple days later, when you're talking to that nurse, you might have some additional questions that you don't remember or forgot to ask.
And members have commented to us that they very much appreciate that. You would think that some people would feel like it's an intrusion, but they don't. They really appreciate that outreach. They really appreciate it being timely. When they come home, sometimes they're confused. There are a lot of bills coming in. They're from many different places, the doctor, the hospital. This has really improved for us, this approach that you've taken. I've received, even just this week, I had a legislator comments about how good that service has been. It's appreciated. It's a great change.
And legislator comments count a lot.
They mean a lot to me, that's for sure. They're my bosses in addition to the county manager, so that means a lot.
So Diane, I think you kind of talked to this one. So, and since you were talking about the immediate discharge, I'm sorry, the immediate follow-up after discharge, it's a good segue into how it didn't actually used to be this way. And at most major carriers, and most carriers, it is not this way. It's frankly exactly the opposite, that what you just described, fast coordinated care, is a rarity because carriers are usually siloed with, and this particular shows client services in one room, claims in another, customer service in another. We could easily add utilization review in another place, and case management in another place, and disease management in another, because in many carriers they're not actually even allowed to communicate with one another for, I don't know, misunderstood HIPAA reasons or something. And to be perfectly honest, and because, we're the Validation Institute, you got to be honest here, NOVA didn't used to be this good. In fact, NOVA used to be, frankly, pretty bad. As you'll see from the next two event rate slides that I'm going to show you. So you saw the previous ones, how good they are now. But these two date to when I was retained by a large customer of NOVA to review their performance. And they did the exact same analysis, but they came up with much worse numbers. So if you look at the years involved, well, we got involved in the baseline year in year one, and you could see that that NOVA was not doing well, versus in this case we used national and also New York State averages. They were never happy to see me. I remember that. I wasn't taking it personally. Measuring outcomes is not a popularity contest, let me tell you. But to NOVA's great credit, they took this stuff to heart and made dramatic improvements, and I mean dramatic improvements over the period that showed up. And this example is diabetes events per thousand, and then this other one is total events per thousand, and this is now wellness sensitive medical events. Those five put together. We got a question early on here that related to the first set of slides that I put up. So, and I normally we're going to save the questions. There's a few places where they're going to fit normally, but if you want a question answered soon, you can ask it. And the question is, have actuaries validated this methodology? To which I say, no, it's exactly the opposite. We validate the actuaries, because here's a newsflash: they make stuff up. So
across the bow there.
So have you said, no actuary ever has said, hey, you know that thing you paid me to validate? Well, guess what? It turns out that it's not valid. No, that doesn't happen. You pay actuaries to confirm what you want them to say. Now, the best example of this, and in the immortal words of, and this one is Casey Stengel, you could look it up. There was a North Carolina Medicaid was spending $1 gazillion on this patient-centered medical home. And they paid an actuarial firm, I won't say who it is, but it rhymes with Milliman, $500,000 to show that they saved money. Well, it turned out, it took me about 5 hours to figure it out. The whole thing was fabricated, just in plain view. They weren't even lying well. And within the next year or two, North Carolina got rid of it, and they saved taxpayers $1 billion. So now I'm going to send it back to Diane. And I think you've kind of sort of started to explain this. Maybe you give a little bit more about the communication, then maybe Jennifer, if you want to jump in.
Sure. So originally when we started, with our customized medical management strategies based on our clients' data, we had gotten into that and we started rolling that out by client. And we were thinking, what else can we do? How can we think out of the box? And I remember my boss coming to me and saying, well, we're going to change the whole company around. We were very siloed, customer service on one floor, claims on the other, et cetera. So what we did was we took team members from each one of those areas and we created little business units. And the associates that sit in those units are responsible for those clients alone. So contained in that business unit is everything from our plan builders, enrollment, medical management, nurses sit on that team, client services, customer service reps, claims adjudicators. So everybody there is working on one client. They get very familiar with the client. And as you know, in a self-funded world, every single client can do things differently.
Right.
And in the Niagara County world, there's a lot of things that they request that we like our staff to be very aware of.
And one of the reasons people self-fund is to have control over their plan and to not have as much regulation from the state or an external body. So I had been asking for years to have a dedicated customer service team. And I think I told Al about this before. I had asked for years. I had no idea Al was pushing on the other side of the house. He was out there fighting the good fight. I might have sworn a little more than Al, but there were times when I was like, why doesn't the left hand know what the right hand is doing in this company? It was driving me insane. And Diane got to hear a lot of it because she wasn't always the VP, but she was always, one thing they did right was put Diane on our account and keep her there. That was very smart of Nova because it takes somebody knowing what self-funding means. And self-funding means that as a plan administrator, my plan is not cookie cutter. I have 6 unions. We put together plans that work for our members. I came here to a meeting and they told me, they called them ships then, but they told me what they were doing. And I was like, finally, because we started in the 1990s before I got to the county. And then in 2004, we had only 100 or so members in self-funding. Eventually, over the course of negotiations, and because self-funding needs more bodies, I moved all of our employees into the self-funded plan, and that increased customer service calls. Well, I wanted a dedicated team who knew my plan. Not having customer service on one floor or 20 customer service people who could answer and get it wrong. This was the way they put it together, it's a holistic approach. And one of the things I remember somebody saying is, if I face the customer, everybody should face the customer. Even internally, it meant something to people. That it wasn't just Diane taking the calls, that then everybody in the group of customer service understood what the client was asking for. I think it probably changed you internally as well.
Right. It creates efficiencies as well.
It's funny, Jennifer, you should say that because I remember I worked at an organization, it was called Interqual. You may have even heard of it. And of course I do trivia, so I got up early on the session. I said, so let me ask you a trivia question. I was trying to think of what you just said, Jennifer. Who is responsible for your paycheck? And I was getting things like, oh, Jackie in accounting.
Yeah.
No. Newsflash. If you're not facing the customer, you're facing someone who's facing the customer. And it sounds like Nova's been doing that.
Yeah.
Now, on the other hand, the average, and this is, and you mentioned 72 hours of discharge, the average time to contact somebody by a carrier is 105 days. Now, I did this analysis, I don't know, about 10 years ago, published it in a magazine. Unfortunately, it doesn't exist anymore. It's either Managed Care or Managed Care Executive. Whichever one is gone is the one I published it. So you can't find it anymore. I don't know where my copy is, but I absolutely swear it was 105 days. And then I still thought that was high, even though all the data was saying, and the exact thing happened to me. So I'm sitting in this exact seat with, my little Iwo Jima picture behind me there, a couple of years ago. and the phone rings, you know, and it says, I won't say the name of the health plan because frankly we're trying to sign them up for Quizzify. So, but it's also the health plan that insures me. But it was a number I didn't recognize from it. So I pick it up because it's the health plan, and it's someone from case management. So I say, well, you know, there's nothing wrong with me. Why are you calling? And she says, I can't tell you. You have to give me permission. And I said, you know, just out of idle curiosity, I got to find out why you're calling me. So yes, you have my permission. And she said, well, you had a surgery for bladder cancer. And I said, oh yeah, that was 3.5 months ago. It was a day surgery. I had a couple of stage 0 tumors and they took them out, quote unquote, non-invasively. I really haven't thought twice about it. So number one, they shouldn't have been calling me in the first place. And number two, if they were, they should have been calling like you do in 72 hours. So we were going to ask, you know, why Nova from a client perspective, and Jennifer, you kind of started, but maybe if you'd like to just take it a little bit farther, the floor is yours.
The reason why Nova, because I have to answer that question, right? Every couple of years for an RFP, or because we've been with Nova for several years now. The whole time I've been there, I inherited Nova. And like I said, it was a much smaller group then because we had 3 funding mechanisms, 6 unions, 5 plans. We eventually got that down to just Nova, all self-funding. And so why do we stay there? Well, because the service is good and because the numbers are good. The wellness numbers are good and our rates are good. My in lieu of premium rate, when I look at what others around our area are paying, you know, is low. And how do I anecdotally value Nova? Well, when my phone doesn't ring, frankly, and if my phone doesn't ring, that means those legislators we talked about, their phone doesn't ring. My county manager, his phone doesn't ring. The worst, if I call Diane and say we've got a problem, it's always for someone like in a high position, and every member is valuable, but when you get somebody who is a decision maker on your plan or who you have to present the plan to, that's a major issue. The other big thing is our retirees. We care very much for our retirees. The people in my office deal directly with them. They have a lot of time to call lawmakers and tell them they're unhappy. And I don't get a lot of that. I noticed those calls decreasing over the years. I think also because the relationship with Diane and her team got stronger over the years too. She knows what I expect. She knows when I need to know about something. And I would say that everybody should look for that in a TPA. A third-party administrator should be just an extension of you and anticipate your issues. Know how you would handle them. If she can't get me, she knows what my decisions would be. That's what I look for. That's why Nova for me.
Well, you know, I'd like to pick up on something that you said about making sure the phone doesn't ring at the boss or at the legislature. I think essentially everybody, and certainly Quizzify, is in the business of making sure that calls don't go to the people above them. And the best example of that is Delta Airlines, which for decades used to have a complaint form, a very official looking complaint form in each seatback pocket. So people would fill it out and send it in. Well, it went to Delta Airlines. It didn't go to the FAA. And eventually they put the kibosh on it because Delta basically had their finger on the complaint scale. So they would always show much lower complaints than the other airlines did. But that's frankly precisely what we are all trying to do in our own respective areas. And in the case of Quizzify, you know, we get very few complaints because what's their complaint about? You know, it's people can call and say, I think your answer should have been A and not B.
Right,
you know?
right.
Well, when we get those, we turn them around. If I'm sitting in my, you know, battle station here, I'm turning that thing around in 10 minutes, you know, because for all I know, they could be calling to complain to someone else in 10 minutes. And when we do, we don't just say, no, you're wrong, the answer is B, because we're rarely wrong about these things. We say, well,
go ahead.
Oh, I was going to say, well, the answer is B, but you know something? You raise an interesting question, and I think we have to, we're going to change the way this question is worded to reflect your concern. And we do that in 10 minutes, and they're just blown away. It takes me a minute, and they're blown away. Yeah.
And you're talking about nobody above you getting the call. It's like, I don't like to be surprised. And the first thing, so that call from a legislator means there's something that didn't come through me that I don't know about. Somebody's very frustrated if they call a legislator. You talk about those response times, I'm not, there are people who are upset because they've had to call customer service more than once. I don't get those calls anymore because that customer service is integrated. So that's an improvement. I don't like to be surprised. My legislators don't like to be surprised, but your quickness of response, it takes me longer if now people above me are involved. If I get the first phone call, I can deal with that right away. And that's the difference.
And I would add something to that as well, which is, I don't know if you've noticed this, but I think it's true in life that the faster you get back to somebody, the lower their expectation is for how much you're going to tell them. So if you wait a week, they're going to expect this huge response. Yeah, exactly.
You must have been working on something really interesting.
Exactly, right. Yeah. Okay, so we will move on to, so I think you've probably, we've been having the conversation right along, so I kind of think you answered this about how you measure the value. You said it's the number of calls you get, it's your rate, it's the wellness, it's the number of calls you don't get that get solved by Diane.
But Diane said something earlier, which I almost said something at the time. She talked about that, when she talked about the wellness with respect to putting in those two cases and how she admitted that maybe the cost to the client went up a little bit at first, the short run cost, but the long run was better. So one of the people that I have to please that values the services, values them differently than I do, and that's my budget director for the county. And he always wants to know, he counts the beans and he wants to know what things cost. For him, he doesn't care about the touchy-feely customer satisfaction. He wants to know what things are costing. And so I had to convince him and show him studies about, the typical 20% reduction you get in putting in wellness plans. And his focus is always on, but they cost you money, but they cost you money, but they cost you money. Does wellness really save you money? I should show him some of your work, Al. He goes over that and over that about, does wellness really save money? And I think your two cases you showed definitely show it. And I look at, we have a consultant that helps us with this, and we've shown slides to our Joint Labor Management Healthcare Committee that includes union members. And we've shown when we did those zero copays, we did wellness and zero copays before the Affordable Care Act. And we were able to show reduction in ER, more emphasis on urgent care. We had zero copay for diabetic supplies. We definitely had people filling their prescriptions. We could show fill rates that were higher. And that's because our medical and our RX are married here at Nova with their sister company. So I think how you measure sometimes depends on who you are, Al. You know what I mean? I think my budget director and my county manager we have a tax cap in New York State. They value the plan services probably differently than I do. I care about the money. I definitely care about what we pay. But I care about customer satisfaction. I care about member satisfaction. I care about lowering disease rates in my community as well as in my county workforce.
Well, and Jennifer, just to build on that a little, I used to do, back before I did healthcare, I don't want to tell you how old I am. This goes way, way back. I used to do some banking consulting, and they had this thing they would call fee income, because you never made any money on the deposits. You made money on fees for various things. Well, when you parse that fee income out, it turned out that about half of it was fees for things that people wanted, like setting up bill pay services and that kind of thing. The other half weren't fees, they were fines. Fines for late checks and fines for mostly bounce checks and that kind of thing. That should not count the same as fees for things that people wanted. So we split them up and made it so that they tried to increase the positive fees that people wanted to pay and not the ones that people ended up paying. And likewise, one of the things you might want to look at for your budget person is taking all the costs and dividing it into sort of good cost and bad cost, you know, preventive wellness cost versus the exact kind of things we were showing about ER, inpatient, that kind of thing. And make the very compelling argument that the more you invest in the good cost, the lower the bad cost is going to be.
And well, one thing that very approach helps with a numbers person, because you are literally showing them a lower cost. I also think that I always admit where there's an unavoidable cost. If I've got somebody with muscular dystrophy, or I've got somebody with MS, I'm going to be paying for their drugs. You're not going to not pay. There's some disease states you are not going to avoid. Right. There are others that you can lower your numbers. You can do biometric screenings. You can have nurses work on that. And in a union environment, sometimes it's difficult. You know, we have some pushback, especially from our law enforcement unions. You're not taking my blood. You're not tracking my, my wellness. But I think because we work with NOVA for a long time, because Diane herself comes out to our Joint Labor Management Healthcare Committee meetings, you develop a trust relationship so that you're invested in the wellness of the people, and they understand that you're not tracking them to be intrusive. You're assisting them in wellness and providing services.
We had a company that invested in hydration stations because
I love that one. I think that's
found
awesome.
that their back pain was related to kidney stones.
Isn't that amazing?
A construction company put those hydration stations out there. So it was an expenditure on their part, but it saved them a lot of money in the long run.
Right. So in the short run, you pay for something. This happens in my workers' comp plan too. People need to understand the people above me, and that's my job. It's my job to make the case. It's your job to help me make the case by giving me the data, which you do, by giving me the anecdotal evidence, which you do. And sometimes we do copy what's done for other clients. We're a larger municipality, but we are able to see the benefits of what others do and copy that, really.
Right. We put those strategies, as we say, on a shelf, because once we've found it somewhere, I think we're consistently looking to see if
where
it's
else
the
can we
same
do
thing
it,
again.
right? Yeah.
So
I think that's cool.
Well, the thing you mentioned about the bean counters, looking at you versus the other comparables, and at your rate being lower, as a municipality, or are they comparing you to other municipalities, or are you comparing just to other groups?
So I have had to do some instructing. I hate to say it, it sounds so like I think I'm so smart, but in the early going, when the county was first self-funding, we would get criticism from people who wanted us to be insured or competitors. And they would come in and compare rates, and I'd say, no, you have to compare apples to apples. Self-funding is different than insured, number one. Number two, when you look at those rates, like, you really have to dig into what are the components of the rate. We all know in self-funding, it's your admin fee, it's your claims, and it's your stop loss. And your claims are your claims all day long, whether insured or self-funded. Your claims are your claims. You can't run away from those. So when they measure, they have to be sure they're measuring against real apples to apples. So I had to explain that a lot as we went through. Now the county is kind of experienced at self-funding, and they get it. And my legislators understand, and even my members understand. The members used to think self-funding meant I get to look at all their claims. And now they understand that self-funding, because they have skin in the game, they pay a percentage of their health care, and therefore, both as taxpayers and as members, they should want the plan to operate at the lowest cost possible. And wellness is a major, major component of that. I can only negotiate so much in a rate. I can only negotiate so much on stop loss. Wellness is where we all meet in the middle. The members, the plan administrator, the lawmakers, we all should support wellness because it definitely drives costs down. The illness you avoid is one that costs you nothing. That's not Yogi Berra, by the way.
No, although it could have been. It sounds like something he would have said. So I forgot what I was going to, actually, while I'm trying to remember what I was going to say, you'd mentioned the people counting the beans. So, well, since you asked, I will tell you as a trivia company where the expression counting the beans comes from.
Oh, good. I want to hear that.
Glad you asked. So in Athens, when they used to vote, that was the first direct democracy, they would give people beans, and you would put the bean for one candidate or the other, and then somebody would count them at the end. That's the expression counting beans.
Ah, did they put them on a scale, or they just counted
They counted them. They actually literally, because they were all different sizes back then. You know, they weren't all sort of, industrialized hybrids. The other thing I was going to mention just skipped right out of my head once again, but I will interrupt myself or whoever's talking as soon as I remember what it was. So let's.
Okay.
So now we're going to jump into a little bit about what the next step in the evolution is for managing these folks and for interacting with your members, essentially engage. I know what I was going to say. So this was to your point, Jennifer, about people saying, well, if we're self-funded, that means people are going to be looking at our claims.
Mm-hmm.
We actually have a question in Quizzify about the role of human resources. And one of the things is in your claims, one is their role is to review your claims and decide what gets paid. And shocking numbers of people will answer one of the questions about assuming that in fact HR does see all your claims.
Mm-hmm.
So that's one of the things we try to educate on when people are self-funded. Now, the other thing you mentioned I wanted to pick up on was you said if you had someone with muscular dystrophy, they were just plain all going to cost you a lot of money, which they are. And one classic fallacy that a lot of consultants will push is they'll say, well, we'll manage your top 20% or 10%, and their costs will go down. Well, there are two types of people in the top 10%. One is the type of person who, say, had a premature baby. Right. And so, yes, of course, their cost is going to go down the next year. Or maybe they're in a train wreck. And then the other type of person is the one you described, the people who have ongoing drug needs. There are not a lot of people who are in the top 10% who you can actively manage down. The ones you can manage are exactly the ones you talked about, the Yogi Berra ones, where an illness that doesn't happen doesn't cost you anything. You want to be as proactive as possible in the population, like the hydration and the construction company.
That example that Diane gave about the hydration, what fascinates me about that one is they took the data on disease states, had to drill down to that to figure out this company was having a lot of people with kidney stones, and then figure out that, well, that means they need to drink more water. That had like several components to it, right, Al? I mean, it kind of used a lot of different areas of what a TPA does.
Exactly, and it does require this ridiculous amount of coordination. It also requires, I hate to sound like a cliche, but going the extra mile in these situations. And most carriers simply are not set up to do that.
We spend a lot of time looking at the data. I mean, everybody looks at their high cost claimants, right? What can we do there? But we spend a lot of time looking at what we call our mid-cost claimants, because they're the ones that are the pre-diabetics. Those are the ones that have the potential to roll into a high cost claimant quite quickly. So we take a lot of time and look at the data at our mid-level claimants, as well as the ones that are not regularly seeing a PCP or those preventive type services.
And we depict that typically on a slide in the form of an iceberg. So we kind of show what's under the water, what's starting to come up. So most people are dealing with the tip. Right. But you got to catch those other disease states that are coming along that are submerged. That's exactly, we've shown that before, and we've shown it with our consultant too. We definitely go after that, because the sooner you start, the more you can prevent.
Yeah, absolutely. So now
these are taxpayer dollars, Al, you know what I mean? Like, I take it very personally. I take the plan very personally, and the members, its performance. And I think that, I don't know, Diane and I over the years have talked about this. Maybe I'm a more involved plan administrator than some, but I definitely push a lot. And that's because I care very much about the outcomes.
Well, I think the very fact that you're on this call means you're a more involved plan administrator. You're the first customer of any kind we've ever had on a call. And frankly, to be honest, after today, I'm never going to do another one of these without a customer.
Oh, there you go. That's great. Well, good luck to those customers too. They get to hear all your jokes too. I like that.
I do tend to recycle them. And some of you who have actually been on my quizzes, on these quizzes before, will notice a couple of recycled questions here as well. So we were, just to go back into that, so we're talking about the mid-price people, the worried well, the folks who maybe they're not crashing, but they have to navigate the medical marketplace, and that's a whole market in there. And in fact, you can address that market before you even know about them with by educating them. As we say, you know, Quizzify is Jeopardy meets health education meets Comedy Central. So here's one of our classic questions, which is how does the radiation in the CAT scan compare to the radiation X-ray? And Mark, we have a polling feature now, and while people are looking at the answer, this is where we address a couple of the questions that came in, and a couple came in early on. Are there no other validated TPAs, meaning validated, I assume, by the Validation Institute? And the answer is no. And this is not to say that there are not other TPAs elsewhere in the country that are validation worthy. There are certainly plenty that are not, but they have to step forward. If they want to be on a call like this, they got to step forward and get validated. Mark, I can submit this too. How cool is that? Usually the panelists can submit. Do we have an answer? Oh my goodness, there are probably some repeat customers on this call, but yes, CAT scans are absolutely full of radiation and they don't tell you about it. So the majority in this case is spot on, 100 to 1,000 times as much. And one of the reasons that this is a cost saver is if you actually look, and let me just go to the next slide, oops. If you look at the US as a whole versus the rest of the developed world in CAT scans and MRIs, this is the other developed countries, the large majority of whom have better health outcomes than the US. We are number 2 in MRIs, but let me tell you, maybe this is just my opinion, but I don't think there's any list where you're number 2 and Turkey is number 1 where you say, gosh, I wish we could be more like Turkey. No, we're you know, Jennifer, you know, I love that you laugh at all my lines because, you know, I used to do this in front of a live audience and then there's always like 4 or 5 people would laugh. But but there's only like 2 panelists here, you know, so thank you for that. Now in CAT scans, we are, as they say in the recording industry, number 1 with a bullet. We are 20% higher than the next highest. And this is actually old data, but it's actually, I like it because it got well displayed. It's actually gone up since then. So one way to reduce this number is by letting people know, as we say at Quizzify, that quote unquote, just because it's healthcare doesn't mean it's good for you. People have to understand the risks, the downsides, the hazards, the cost of this as well. Very easy to spend somebody else's money. A lot of people go in fact, a story I should tell you is I was at another health plan. This one I can tell you the name of because they didn't sign up for Quizzify. Medical Mutual of Ohio, or let's just say it rhymes with Medical Mutual of Ohio. And I was giving this presentation and somebody in the back raised their hand. They said, and the next slide is, CAT scans are especially bad ideas for children because their cells are still dividing. So someone in the back raised their hand and said, well, my daughter's had 3. And I said, what doctor would order 3 CAT scans on a young girl? She said, oh, I demanded them. So this is, if we just can end or dramatically reduce the number that get inappropriately demanded, you'll make a big dent in the spending here. Okay, the next question is, one of these 2 or both or neither is a freestanding emergency room. The other is an affordable urgent care center. One is expensive, one is cheap, or maybe they are both freestanding emergency rooms or both urgent care. So your choices are, is it A that's expensive? Is it B that's expensive? Or they're both urgent care, or are they both freestanding ERs? And meanwhile, we got a couple of questions in early on because I put the text number up there. And so while we're waiting on this, The rates that you showed seem very low, meaning the chronic disease rates, like 2 per 1,000 for diabetes, and also for CAD, including ER visits. Those seem very low. Well, the answer is they're low because they are low. And in fact, wellness, as you described, has to be fairly broad and cover things like maternal, musculoskeletal, a whole bunch of things, because the actual number of people, probably higher at Niagara County, I'd say, because your workforce is older, but the number of, and of course you have your retirees, but in the under 65 insured population, per 1,000 belly buttons covered, the average organization will have 1 heart attack and 1 person going into the hospital with a chronic disease, primary diagnosis of diabetes. So you got to cover the landscape. And that's why those rates are so low. The total per 1,000 is going to be like 60 admissions per 1,000 and a couple hundred ER visits. Okay, Mark, I got to submit that. I didn't submit it. Do we have a, yes, okay, this time the plurality actually, almost a majority got it right. The first one is in fact a freestanding emergency room. Now you might say, what's the difference? And so the freestanding emergency room is licensed as an ER, and well, if you stumble into it if you have a real emergency, frankly, if you have a real emergency, you probably want to go to a hospital. But if you can't, if you need to get someplace close, you want a freestanding ER. But if you just stumble in there for a few stitches, you could get you will get a 4-figure bill. Not could, will. This, on the other hand, is urgent care is one of healthcare's great bargains. To the extent you have any bargains in healthcare, this is it. How do you tell the difference? Well, they make it very hard, but these have to be open 24/7, and they have to say emergency on them. These can't say emergency, and they generally are not open 24/7. Okay, so now speaking of wellness, let's do a pure wellness question. What is wrong with this picture? A, her legs are too bent. B, her neck is too far forward. C, she shouldn't be doing sit-ups in the first place. Or D, should be left elbow to right knee and vice versa to get the maximum back rotation. We have actually one more question.
I don't know.
Actually, no. I think we answered the 3 that have already come in. Mark, did we get any yet on the? Mark, we didn't have any come in on the Q&A, have we?
No, I don't see one there.
Okay, all right. Because I got a few. I think there might be one more on my list. So let's. There is a
note in the chat.
Okay. Well, let's. Next time we have the pause in the question, we'll get to the note. So, and the answer is, Mark, put it up. She shouldn't be doing sit-ups in the first place, got 41%, and that is indeed the correct answer, okay? The 1980s called, they want their exercise back. It turns out that sit-ups are like the most overrated exercise on the planet, and you shouldn't be doing them. If you want to do your core, you should do planks, as is demonstrated right here.
That's a good point. I would say too, Al, on the answer, I liked the answer. I was with Diane on that answer. She shouldn't be doing sit-ups in the first place. But as a risk management director, I'm concerned she's doing them on a roof with no, like, what is that? I hope she's not running sprints next. That would be bad. Healthy.
So yeah, so I will also vouch for the value of doing planks, not on a roof, in 90 seconds, and my back pain, poof, gone.
Wow.
Okay, so here's an interesting one, and this is our last, and then we'll turn it back over. Roughly what percentage of cavities need to be drilled and filled? A, virtually all of them, because the decay is only going to get worse. B, the large majority, because 25% will go away on their own. C, half of them. The other half decay so slowly you can probably outlive the problem. Or D, roughly a third. The others can be quickly and painlessly treated for $30 with a special solution your dentist doesn't want you to know about. So I think we had one other question come in early. Oh, hang on. Actually, no,
There's
we
one
didn't.
about CT scans in the chat, Al, and
Okay. Yeah, I
it's
can't see the
about.
chat, so go for it. Yeah.
It says, while providers ordering CT scans are clearly imperfect, you can always pull stats on unnecessary use. Realistically, there may be many cases in which trained providers may be better judges in which imaging modality is appropriate, as opposed to the average patient, even a patient who's answered one multiple choice question, in parentheses. Providers are aware of risks and benefits. How can you be confident that a question like your CT question won't do net harm to patients?
Well, I think the fact that we do 20% more than the next highest country and twice as many as everybody else, and that every single journal article that has come out that say we vastly overscan people, and that actually scans themselves can often find what's known as incidentalomas, which are findings that they were not expecting to find that suddenly you have to get treated. They happen so often there's even a word for it. I would say that the likelihood of somebody not demanding an inappropriate scan, the likelihood of somebody not demanding a scan and being harmed by it is vastly less than the likelihood of people demanding scans. And
yeah, and we
well,
also
you know
say,
what I mean. You know what I mean.
Yeah, and we also say right in the question that we're very careful saying that sometimes you might need a scan, and but we're encouraging people to ask a couple questions before they agree to it. We
Yes, and in fact,
never say don't do it.
I think it just makes it a more informed consumer to have that dialogue between them and their physician about, is there another option, or is it absolutely necessary that I have this
I
scan?
mean, it's important to have informed consent. It's important to know. Most people, a doctor orders a CT and they get it. I don't think people even know the level of radiation. They don't.
oh, they have no idea.
Right.
They don't. I ask these questions about mammograms. Everybody's very much into that culturally. We have huge centers for it, and now they're doing 3D mammograms, and everybody has dense tissue, and they'll also do a sonogram too. And I ask those very questions. I have no history of breast cancer in my family, and I asked, why do I have to go for these? I'm being bugged to go for these. I'd like to know what my exposure is. And they claim it's less than a chest x-ray by quite a lot. So I was intrigued by your post here. I thought that was very interesting.
Yes, a mammogram is less. Yes,
But
a mammogram is less than a test. The risk of a mammogram, and by the way, just to wrap up Mark's point, if you actually do go look at the question, it actually says just exactly what you just said, Jennifer. Just bring this up with your doctor. You know, don't say, I'm not getting a CAT scan. Just say, what are the risks? Are there any risks? Is there another way of getting it? Now, the mammograms are actually less radiation than a chest X-ray, but you're doing them so broadly, and you're doing them over so many, 5 times or over a decade. So, on balance, the average person is probably better served by mammograms, but it's a balancing act. And I actually know somebody on the U.S. Preventive Services Task Force. Went to college with her, and she said that when the evidence very clearly said that instead of starting at 40 and doing them annually, you should start at 50 and do them every other year. Cost has nothing to do with it. It's all about the harms of false positive, of which there are huge numbers. As you say, a lot of people have dense breast, and the possible harms of the radiation. And they said when they went from 40 every year to 50 every 2 years, they got incredible amounts of pushback on that. Sure. Largely funded by the people who make the X-ray, exactly. The mammogram. Yeah. So, Mark, do we have an answer on this one? Okay. Oh, something. This is pretty amazing. Okay, this shows that people remember Quizzify because we have, I guess, a lot of repeat visitors here. In fact, the vast majority of cavities do not have to be filled, and your dentist is not telling you about this solution because it only costs $30 and they don't make any money on it. I know I sound like a conspiracy theorist, and there is in fact a question in Quizzify about cures on the internet. It says, how can you tell a cure is phony? And one of the choices is doctors don't want you to know about it. This is the exception to that rule. One exception to that rule is that most cavities don't have to be filled anymore. there's this is not like some alternative therapy. This has been FDA approved for 7 years, and it's used in Japan. They don't fill any cavities anymore. You can find all sorts of articles on it. One just came out a few weeks ago. This is a classic where all you need to do is educate employees, and they'll take it from there. You saw in the polling question how people remembered this answer. Nobody's going to forget. Nobody who has kids, nobody who ever gets cavities, nobody who has parents with cavities. So with that, I will turn it over to, oh wait, hang on a sec. I just got a question come in here. How come we haven't heard of this stuff?
Because the dentist doesn't want you to.
Well, yeah, it literally, I mean, it's covered by not most, probably the majority of insurance covers it, but there's nobody advocating for it. I mean, it costs so little that the company that makes this stuff, it's called Elevate Oral Care, and the stuff is called Advantage Arrest. The company that makes this stuff sells a whole bunch of things to dentists. Now, if they started marketing this direct to consumers, they'd lose all their customers for everything else. Yeah. So we're going to wrap up here, and this is perfect timing, about some of the old ways that things have been done, and how Nova does things a new way, and how most consultants who get paid a lot of money based on how thick their RFPs are will not be looking at the new ways. They'll just be doing a ton of stuff. And this is where I quote the immortal words of the great philosopher Yogi Berra, who once said, "We don't know where we're going, but we're making good time." So with that, Diane and Jennifer, do you want to comment on doing new things versus old, and how RFPs get in the way?
I think that the one thing I hear all the time is, performance guarantees. Can we get performance guarantees? And that one is difficult. Yes, we have performance guarantees with the county. However, when we're looking for new ways, I always like to ask, is it more important for us to make sure that your member is off the phone in 4 minutes and 30 seconds, or that we've done all the research, we've helped them find a participating provider, and they had first call resolution. So they don't need to call us back. And that's a happier member, that's a happier client, that their members are not, saying, they kind of rushed me off the phone. Yeah. So that's one thing. I could go on and on about RFP questions. In fact, we did a little webinar once on that. Network discounts are a big thing in my mind. So I don't know if you have anything you want to say.
Well, with respect to RFPs, I'll take that one first. Just remember, when you're writing RFP questions, every question you write is a question whose response you then have to measure. And that's a pain in the you-know-what, okay? And you have to make the questions something that the response will be measurable, first of all. Second of all, you have to really care about it, or don't put it in there. The thickness of your RFP does not determine the price you get. It's really kind of ridiculous. With performance guarantees, actually, it's the same point. If you agree to a performance guarantee, then you got to track it and you got to measure it. So you as the client have to measure it, because the vendor's going to measure it, the TPA is going to measure it, but you're not sure they're catching everything you think is not a satisfactory performance. So I have a team of people at my office, but one main lead healthcare person. And if an issue comes up, I say, put that on the issues log. Put that on the issues log. Then those issues logs go back to Diane and her people for us to measure, did we answer this question? Did we solve this problem? Now, with respect to solving problems, the one thing, Diane is right. I care more that the problem is solved for the member than whether their call is under 2 minutes. I frankly have never had a call in my life that was under 2 minutes, so I don't really care about that. But I would say that the one thing that really annoys me, and I make sure that my TPA and my own team do this, is I don't want to solve an issue. When a question comes up, I want to solve the problem. So it's not just, member A has an issue. I want to fix it so that issue doesn't happen to anybody else. So I don't like the quick, oh, we solved that issue for Jennifer. No. Why did it happen? How do we avoid it ever happening again? You know this is my thing, right? I don't want to fix it for that person, Al. I want the problem fixed, systemically fixed.
So we have to wrap up, but to your point, Jennifer, there is one thing I want to add, which is the example you gave is just like in Casablanca, where Claude Rains says to the Gestapo agent, "Owing to the seriousness of this crime, we've rounded up twice the usual number of suspects." Okay, no, you want to find the criminal. You don't want to multiply the suspects.
Exactly.
So we very quickly ran out of time. I don't know how that happened, but just remember as you listen to this, that this is not just us, chatting away here. We've actually put our money behind these folks. The Validation Institutes put their reputation behind these folks, and you will have the opportunity to contact these folks. You will all be getting copies of this in the next 24 hours. And thank you so much for being with us. And thank you especially, nothing personal, Diane, but I'm especially going to thank Jennifer for being the first customer ever to be on a phone call.
Oh, I appreciate being asked. This was just fabulous. Thank you so much.
Our pleasure. Okay, we'll be signing off, everybody.
Bye, everybody.
Bye, everybody.